So next we move on to a debate which is mainly structured around the surgical management of stress incontinence, and the question of whether to use mesh or not to mesh is very topical in that area at the moment. So I thought that would be an interesting crux point to focus our debate on. But we will talk about all the major management options for surgical management of stress incontinence as well. So from that point of view, I'd like to introduce Professor Stephen Jeffrey, who's the head of the Department of Urogynecology and Pelvic Floor Reconstruction at the University of Cape Town in South Africa. And he's also served as president of the South African Urogynecology Association. And Professor Jeffrey will be talking to us about the role of mesh in the surgical management of stress incontinence and why mesh still remains a good option. Professor Jeffrey, over to you.
So this is a debate that is relevant, it's important. We're seeing many patients with stress incontinence, and it's an issue that has affected the way we treat patients quite extensively over the last decade. And so thanks, Arjun, for putting this on the program. In South Africa, we still do a lot of slings. And so, of course, for me, it's to mesh, of course. There's no question about it. And unfortunately, however, both the synthetic slings that we use, including the retropubic TVT over here and the transobturated tape, have received a very, very profound thumbs down by some of the patient group bodies. And this has really set up in motion a tide against the use of these synthetic slings, and which has affected practice quite extensively in some countries. And I think the country that is the most severely affected is unfortunately the UK. Now, these are the issues. A lot of it has been driven by patients. This is a Twitter hashtag TVT, and there you can actually see where a patient group has said that if it's good enough for chickens, it's good enough for women. And there's obviously a facetiousness in that whole statement where they are criticizing the use of these products in patients. Now, a lot of this was very much driven by a number of patients who developed ongoing chronic pain. And I do not want to minimize the impact of that on patients. In fact, in the last week, I've got a patient who's actually had to be boarded from her work due to pain following the mismanagement of a transobturated tape. So I certainly don't want to minimize the impact of a mismanaged complication of a transobturator or retropubic tape. But in my belief, these are still very good and very important procedures for us. And when they're done in the right hands and managed correctly, you will not have any complications. This is the type of complication that we do see. This is a patient that I saw where you can actually see the TVT was actually placed through the urethra, and this can be very difficult. So admittedly, there are significant issues related to these procedures. This patient needed a formal removal of this and followed by a fascial sling a few months later. So significant problems, but if managed correctly and recognized in time, I still think TVTs and transobturated tapes aren't bad procedures. Another type of complication, this is a tape that was no doubt placed inside the bladder, not recognized again at surgery. And here you can actually see the tape in the bladder. And if left for long enough, can get complications like stone formation. Obviously, there are some patients who have other problems. This is a patient that had a huge retropubic hematoma following placement of a TVT. So our other issues other than mesh-related complications, he has another hematoma following a transobturated tape. And obviously, we all know that these patients can also get erosions. This patient might have presented with some discharge or, and in many cases, the partners do start to feel this exposures. And this is another reason why these procedures have, in fact, received a lot of negative publicity in different parts of the world. I do think it's often the exposure to the English media that would drive the patient to be, prejudiced against having one of these tapes. I do think, however, it's gone overboard. I think this specific group of doctors, in particular, you can actually see there's a professor of evidence-based medicine who has said that TVT and the scandal associated with this is akin to the thalidomide scandal. And I certainly do not agree with that. I mean, we have to ask ourselves, is that the same as a sling? And we know that in the correct hands and in the correct expert management, these remain good procedures, and they are very, very much endorsed by the large urology and urogynecology bodies. So you can actually see, just to go back to one of the very first groups that investigated the TVT, and this is the retropubic TVT, and this was actually written in 2013 already, and yeah, they've got 17-year data on the TVT. And yeah, we have a 90% cure rate. I can't think of any other operation for stress incontinence that has such good long-term data and safety data, and most certainly in this data, it was shown to be not only effective, but relatively safe. For the other data, there's some good data now getting beyond 5 years for both the transobturator and the retropubic tape. And yeah, you can actually see that up to 5 years, definitely about an 85% cure rate for both devices. So certainly standing the test of time in terms of long-term data. So let's then spend a little bit of time. No, we don't have a lot of time, so we're going to jump right into it. And I'm sure my colleague, Dr. Harding, will be talking about some of the alternatives. And let's look at some of the alternatives then. What about the Birch copper suspension? The Birch is having a heyday. It's having a resurgence. Even in my hands, I'm having to do more laparoscopic Birch procedures. I know many of you are exposed to this operation, but for those of you who have grown up more recently, you might not have seen this operation. But basically, it involves the placement of sutures in the perivaginal tissue here and attached to the iliopectineal ligament. A good operation, most certainly the gold standard before the invention of the TVT. But how does this actually compare to the TVTs? So this is the Cochrane review where they do look at this operation. And in fact, on this systematic review, when you looked at objective cure rates comparing laparoscopic Birch copper suspension to the mid-urethral sling procedures, unequivocally shown to favor the TVT. So when it comes to efficacy, there is no doubt that the mid-urethral TVT procedure is better. What about morbidity, complications? Hospital stay, 1 day with the TVT, much better than the Birch. Return to daily activities, much better. Operation time, better. And for other complications, no difference between the two procedures in terms of reducer of activity and voiding dysfunction. Just looking at another systematic review, again, data suggesting that the TVT is better than the laparoscopic Birch copper suspension. And overall complications really aren't much different. So, ladies and gentlemen, are we throwing out a perfect operation, a very good operation, in favor of something which not only has the same or similar complication rates, but a poorer efficacy? So is the Birch copper suspension a better operation? I certainly don't think we can say that based on the data, not based on patient manipulation and patient pressure. And it's not only better from a efficacy and efficacy complicated point of view. In today's age, when we are very cost-driven, the TVT is significantly cheaper than the copper suspension. You can actually see that on this study from Finland, where they actually showed that. There's also been a resurgence in the use of the fascial sling. And how does this look? I mean, is this better? Is it a better alternative? For those of you who don't really know how this operation is done, the way I do it is I dissect out a piece of rectus fascia, about 8 by 1.5 centimeters wide, remove the whole thing, place 2 Prolene sutures on the end of this, and then basically put it in my hands, we normally put it mid-urethally, so it's very similar to the placement of a retropubic TVT. And then we will tie these strings in the midline over the rectus sheath, and thereby doing something very similar to a retropubic T. But the advantage, of course, is that you're using the patient's own tissue. It's autologous, and all the issues related to the synthetic slings are not associated with this device. So just then looking at this study where they did, unfortunately, not big numbers, not a lot of comparative data between this and the TVT, but obviously the fascial sling took longer because it's a lot more faffing around. There was more voiding dysfunction in the patient who had the fascial sling, because remember, it's a little bit more difficult to tension this device, and it is more operator dependent. Stayed in hospital longer. Remember, there's an abdominal incision with this. Associated with that, you can get wound sepsis. And again, I do think one tends to make it a little bit tighter, and also more residual and voiding dysfunction again when they followed these patients up between 6 and 12 months. And again, there wasn't much difference in self-reported de novo urgency incontinence. I just thought it would be interesting. This is actually from our Cochrane review that I did with Arjun, and this will be published soon. This is the second or third edition of this. And I urge you to look out for this, because the single incision slings certainly aren't looking too bad at the moment. But there you can actually see that even the single incision slings weren't much different in efficacy compared to the traditional slings. And so that is just something to be on the lookout for. There's also been a huge uptake in bulking. The most common one that we use is the Bulkamid. I think the one that is obviously received the most traction over the last few years. It's a very inert procedure. You can actually see it's placed at the mid-urethra, about 1.5 centimeters from the urethral meatus. I normally place 4 blebs. That then occludes the bladder neck and produces continence in that way. Very nice procedure, almost no complications. In fact, I always say to my patient, there are no complications associated with this. And, not a bad procedure in a patient who's really scared of a synthetic sling. But if you want someone who wants efficacy, what is it really? Now, in the data that you get from the company, you can see that they do quote something between 80 and 90% cure rate, but this is not cure. This is cure and improved. So I want to urge you to be careful when you look at the data on these procedures, because a lot of these patients aren't actually much better. And there was a randomized trial. This is from Tommi Mikkola in Finland, and randomized between retropubic TVT and the Bulkamid, which is this polyacrylamide hydrogel injection. And when they looked at 1 year, objectively, only about 58% of the patients in the Bulkamid arm were cured, that was on cough stress test and pad test. And if you do go and read this paper, I do want to warn you that they did do an intention to treat analysis. So some of the patients that they report as being cured in their arm of Bulkamid have actually had a TVT. So they actually did TVTs as a rescue procedures in this paper, and they actually gave about a third of the bulking patients a repeat bulking procedure as well. So be careful when you read this data. And so in final, I just really want to go back to IUGA. IUGA has come out in support of the use of the mid-urethral slings. This was signed by at least 30 to 35 urogynecology associations from the affiliates around the world. And here you can actually see the justification for this position statement. They say polypropylene material is safe and effective as a surgical implant. And here you can actually see that they recommend it as the first line. And even the FDA in America has stated that polypropylene is safe and effective in the treatment of SUI. And even the European Commission inquiry on the study of surgical meshes supports the continued use of these slings for incontinence. So in conclusion, they do say that they've helped millions of women worldwide, and I certainly agree with that. It's got acknowledged safety and efficacy, and it has allowed women to have safe access to treatment. Certainly supported by IUGA, and this is one of the reasons why I continue to offer my patients the retropubic TVT as a first-line treatment for surgical treatment for stress incontinence. In my practice, really just getting down to the final issues where it comes down to risk perception. And as a group of surgeons and doctors, we need to be driven by data, we need to be driven by governing bodies, and not manipulated by politicians and by patient groups. And again, just the final thing here from the Cochrane Review, where they again state and they support the use of these slings based again on data, and which I think is the most important. So I think they're the best option for the surgical management of stress incontinence. Very good long-term data. They are safe. It's a reproducible technique. They cost and they're cost effective. Thanks so much, and I'd be very happy to hear Chris Harding's opinions on the other side of this argument. Thanks so much.
Thank you very much, Professor Jeffrey. That was a comprehensive overview of the benefits of using synthetic slings, and I've had to look through this evidence over the last few years in great detail, and I can see exactly where you're coming from. The data is, as you say, quite robust, and overall in surgical trials at least complication rates are low. So I'm very interested to hear our next speaker and his views to the contrary. So we have Mr. Chris Harding, who's a consultant urologist and head of functional and reconstructive urology at Freeman Hospital in Newcastle in the UK. And he's also the chair of the EAU guideline panel for non-neurogenic female LUTs. And Mr. Harding will be giving us the other side of the argument, which is against the use of mesh in the surgical management of stress incontinence. So over to you, Mr. Harding.
My name is Chris Harding. I'm a reconstructive urologist from Newcastle, as Arjun said, but I've also been the mesh lead for BAUS since this whole controversy started. So I've kind of lived through it for a long period now. My disclosures you can see on the screen there. So I've got to argue against something that's been described as the gold standard in stress incontinence surgery. Indeed, the FDA tell me that polypropylene slings are safe and effective. IUGA and the American Urogynecology Association talk about monofilament polypropylene mesh as the most extensively studied anti-incontinence procedure in history. And I accessed the AUA website just yesterday, who told me that any restriction in the use of synthetic polypropylene mesh would be a disservice to women who choose surgical correction for stress incontinence. So that's my conclusion. I don't think I can win this one, or can I? So when we look at regulators, guideline makers, we've got to look at what they said at the beginning in order to unravel this whole mess. And the first thing was from NICE in 2005, who urged clinicians to inform women that there was a lack of long-term outcome data regarding synthetic midurethral slings. This was backed up by the Cochrane collaboration, who talked about an urgent need for high-quality studies, particularly with long-term follow-up. The FDA in 2008 identified serious safety concerns and adverse events with transvaginal mesh as a whole. Now, it's important that we keep things separate when we talk about transvaginal mesh, and we, for the purposes of this debate, are going to talk about suburethral slings for stress urinary incontinence. So if all of these bodies have had a lot to say in the first part of the century, we now sit here in 2021. So surely everything's changed and we've righted all those wrongs, have we? So the Cochrane review that probably gets the most citation and description is this extensive search of 81 trials, over 12,000 women, that concluded that midurethral sling surgery was the most extensively researched surgical treatment for stress incontinence. It reported 80% plus cure rates or improvement rates, but we have a few issues here. This is, remember, the highest level of evidence we can get. This is a systematic review and meta-analysis, which told me that most trials didn't describe their methods clearly, that there was a need for long-term outcome data reporting, and despite 81 trials being included in this review, there was uncertainty about the long-term effectiveness and the adverse event profile. So I would question their use of the term extensively researched. More recently, we had an even bigger project, a network meta-analysis of randomized controlled trials. You cannot get higher level evidence than what I'm about to show you. This was 175 randomized controlled trials, over 20,000 women, and again, it confirms an 80% cure rate with a retropubic midurethral sling. Now, what was interesting is this is one of the first large meta-analyses to actually point out that there is a reduction in efficacy with the transobturator route, and they describe only a 64% cure rate with a transobturator tape. But when you drill down, it's interesting. Despite all of this evidence that they've collated, they come to the conclusion that current evidence from RCTs is not sufficient to establish long-term effectiveness and safety of surgical interventions for stress incontinence. Now, that's not confined to midurethral tapes, but this is the subject we're debating today. The network meta-analysis also suggested that we need a better understanding of these complications, and they talked about that as being imperative. So we're really getting a strong steer here that the existing research, on which we base our practice, is perhaps flawed. So we've got some real world data. Now this, again, high-level publication. This was in Nature Scientific Reports, and this is a UK study of hospital episode statistics data from 2017. Again, a massive amount of patients included, over 90,000 patients, 56,000 had TVTs, 34,000 had TOTs, and the majority were what we call unconfounded. They had no concomitant procedure. They were isolated suburethral sling surgeries. The peri-procedural complication rate was over 2%. The 30-day complication rate following discharge was approaching 2%, and around 6% would be readmitted over the subsequent 5 years for either further intervention or for symptoms of mesh-related complication. In total, the 5-year complication rate in this cohort of over 90,000 women was reported at almost 10%. So that is significant. We also have some commentary from Carl Hennigan, who was mentioned in the last talk. Carl Hennigan is Professor of Evidence-Based Medicine at Oxford University, so he has reasonable credentials to describe clinical evidence. They pointed out that the majority of the new devices that had been introduced since the original TVT were approved based on equivalent, i.e. no further testing was required. They quantified that and told us that only 2 of 61 new devices were classified as unique, despite design changes being present in them all. Now, here's something that's really telling. In 2012, in response to the safety concerns, the FDA asked 33 manufacturers to do some further safety testing on midurethral tapes. 2/3 of them responded by withdrawing their product, which I think speaks volumes. The FDA added that the mesh trials were poorly designed, poorly conducted, and failed to account for variable lengths of patient follow-up. So the evidence is looking now far from concrete. So what do the women think? Well, women are voting with their feet. So in the year 2016 to 2017, there were just over 7,000 patients who had a tape insertion procedure. And this was a reduction of almost 50% from a similar period about a decade earlier. it's not just happening in the UK. If you look at the Urogynecological Society of Australasia, they also report that young women are now more likely to put up with their incontinence due to concerns over the mesh implants. They quantified it also and described a 41% decline in stress incontinence surgery in that age group since the peak rates in 2009. Now we come to something that's absolutely unparalleled in the history of surgery. So this is a letter that was sent to all UK NHS trusts by the NHS Central Office and requested that the use of suburethral tapes and to treat stress incontinence and also prolapse mesh would be restricted, i.e. banned, in the summer of 2018, and the ban has not yet been lifted. Furthermore, there were calls for a parliamentary review, which was completed in July of 2020. These are quite unprecedented events when you look at any particular surgical procedure. First, it was banned. Secondarily, parliamentarians called for an independent review, and the independent review concluded that there were significant adverse events following pelvic mesh surgery, not just restricted to pelvic symptoms, but also other issues which may include autoimmune conditions and psychological effects. So a summary of the recommendations for what constitutes around 2 years' work involved two quite striking recommendations, again unparalleled. The first one, there was calls for the UK government and the NHS to issue a fulsome apology on behalf of healthcare system to families that were affected by pelvic mesh. Where have you ever heard that before pertaining to a surgical procedure? The second thing is that the complications associated with pelvic mesh can be so severe that they advised networks of specialist centres need to be set up to provide treatment for those affected by pelvic mesh. So again, we're in uncharted territory here. There's also the litigation aspect of it. So in the US alone, over £8 billion has been paid out to claimants. In Australia, a large class action was successful in 2019 against Johnson & Johnson. And in the UK, the largest single biggest settlement to a patient was over £1 million. And I would just point out that other procedures are available. So if you look at that ESTA meta-analysis that I showed you earlier, that showed you that traditional autologous fascial slings had the highest rating for cure of stress incontinence. The Cochrane review on Colpo suspension commented that it was an effective surgical technique which would result in long-term cure for most women. The Cochrane review on autologous slings says that autologous fascial slings may be better than Colpo suspension in terms of cure and also have lower reoperation rates. Finally, when mesh goes wrong, it goes very wrong. Erosion into the urinary tract is not easy to treat. It often involves an extensive pelvic dissection, denervation to important parts of the urinary tract. You can see on the left-hand side of the slide here, it's just infiltrating into the bladder neck trigone area. This is a sigmoidoscopy showing mesh going through into the bowel, and this is mesh erosion on the anterior wall, which again will require an extensive surgical dissection to treat. Finally, this is a death certificate from Scotland where mesh was included on the death certificate for the first time, which just illustrates the possible gravity of the complications that can be suffered by the patients. So in summary, I've shown you that mesh has a significant rate of complications, 10% in real-world data. The long-term data to support the use of mesh is poor, and that's not my words, that's the Cochrane collaboration, large network meta-analyses. Alternatives are similarly effective, but we don't hear, descriptions of such a high magnitude of complications. This was the first surgical procedure, certainly in my career, and I think in the history of surgery in the UK, to be banned. They're highly complex complications, which you don't see with alternatives, and there's a high risk of litigation. So I'll leave you with a a quote here from Carl Hennigan, who, as I said, is the professor of evidence-based medicine at Oxford University, an institution you may have heard of. And he has said that one woman saying there's a problem could be an outlier. But if you look at groups from across many countries, you've got over 6,000 women in a UK group alone and over 100,000 women in the US involved in illicit litigation, then you have to accept that there is one humongous problem. I shall leave it there. Thank you very much for listening.
Thank you very much, Mr. Harding. Well. So we've had two exceptional presentations there, which I think highlight the complexity of the problem. And I'm not sure that it necessarily makes our listeners, puts our listeners in a better position to evaluate that evidence and decide what they want to do in their own practice. But I think it does start the conversation, and it does point out the fact that purely looking at the evidence does not always give us the entire picture. So if you do have any questions, feel free to ask them. We will go through a few more of these points, and I'd be interested to get the opinion of some of the other panel members as well when we come to our Q&A and case discussion section at the end.